Ladies and gentlemen, thank you for joining the HealthInsight Nursing Home Resident Safety Collaborative Kickoff conference call. At this time, all lines will be muted. There will be an opportunity to ask questions later during the call. Your hostesses for today are the HealthInsight State Leads. Our first speaker for today is Shannon Kupka. You may now begin.
Good afternoon, everyone. My name is Shannon Kupka, and I'm the team lead for the Nursing Home Project in New Mexico. For the next 90 minutes, I and my project teammates will take you through the second part of our collaborative and what to expect. We will ask you to give feedback as well via polls throughout the presentation. There will be plenty of opportunity for questions at any time during our presentation through our chat feature. Additionally, we'll have time for question and answer at the end of our presentation. And today's presentation will be recorded and placed on our website hopefully within the next week so that you can share this with colleagues unable to make it today. And at the conclusion of our presentation, there will be an evaluation survey which we will be asking you to fill out. Please complete this, particularly those of you who would like to obtain continuing education credits. So just a quick bit about who we are. HealthInsight is the Quality Innovation Network Quality Improvement Organization in a 4-state region serving Nevada, New Mexico, Oregon, and Utah. We work on a variety of initiatives for the Medicare program. And this collaborative is part of a 5-year contract with CMS. We're about at the halfway point as we roll out this collaborative. We provide healthcare quality improvement learning opportunities focusing on patient-centered care, making care safer and more affordable, and improving population health. Next slide. Let's look at who is on the team. The HealthInsight team working on reducing healthcare-acquired conditions in nursing homes consists of the following team members. We have Donna Thorson, who's the project manager in Nevada, Leah Brandis, who is the lead project coordinator in Oregon, Michelle Carlson, the project manager in Utah, and myself, Shannon Kupka, the project manager for New Mexico. Next slide. Our multi-state effort also includes project manager Lynn Kemper out of Oregon and our multi-state project assistant Lisa Barton. Those of you working on our C. difficile project know Lisa very well by this point. Next slide. So what are we looking to accomplish today? At the end of the next 90 minutes, you'll be able to describe how the collaborative aligns with other national initiatives you're involved in, the new requirements of participation, and your quality assurance performance improvement efforts. You'll be able to explain the structure of the collaborative, plus we'll be giving you a sneak peek at our upcoming events, and you'll be able to identify what the collaborative goals and expectations are and be clear on your next steps. Next slide. So we want to recognize the context of the collaborative. There have been a lot of changes and initiatives just within the past few years. We want to emphasize that the HealthInsight Collaborative is not intended to be an additional program to your work, but rather a way to support you. Participating in the collaborative will support your QAPI, Quality Assurance Performance Improvement Program, by providing opportunities to document your performance improvement projects so you can take credit for the work that you're doing. We have a subgroup of the collaborative that includes 63 nursing homes across the 4 states who are focusing on C. difficile infections. They've just completed preparation to report into the National Healthcare Safety Network online portal and will be reporting their infection rates into the system to establish a national baseline. Lisa Barton will be sending an invitation soon to this cohort for an upcoming webinar on reporting. Next, we'll be providing education sessions on infection control, antibiotic stewardship, and staff communication. Those of you in the C. difficile cohort will be light years ahead in the development of your infection control program. However, all collaborative members will be able to take advantage of any resources and webinars directed toward antibiotic stewardship, infection prevention, and team communication that we'll be providing with the C. difficile cohort. We know that you care about your 5-star rating, and your performance improvement projects that you do to address the quality measures will be reflected in your 5-star rating. Addressing issues of resident safety will also benefit your hospital readmission rates, make you attractive partners within the healthcare system, and position you for value-based payments. Next slide. So let's get your feedback in a quick poll looking at adverse events in skilled facilities. Quickly, an adverse event is described in a report by the Office of Inspector General. It describes harm to a patient or resident as a result of medical care, which includes failure to provide care, and events involve such things as medication errors, events related to infections, or events related to ongoing resident care. So, how many Medicare beneficiaries were harmed by an adverse event or temporary harm event within the first 35 days of their skilled stay? Let us know what you think.
Hi, this is Lynn. I had a little glitch with the poll. I'm not sure what showed up.
Put it in the chat.
Okay, I'm going to start over. I think I'm on the right slide here. Let's try this.
Okay. So, take a moment and indicate whether you think it's 1%, 5%, 10%, 30%, or 50%. Okay. Let's see what answers we came up with. All right. Well, a lot of you chose to reserve your answer, but we do have a percentage of you that rated 10%, and some of you 30%, and a couple at 50%. So let's go to the next slide to actually see. It was actually 1 in 3 Medicare beneficiaries that were harmed by an adverse event or temporary harm event within 35 days of admission to a skilled nursing facility. Okay. Next slide. The Office of Inspector General determined that nearly 60% of those events were preventable. This is where the Resident Safety Collaborative comes in. Factors contributing to preventable adverse and temporary harm events included substandard treatment, inadequate resident monitoring, and failure to provide treatment. As providers of healthcare services to older adults, it's our responsibility to prevent such adverse outcomes. As we know, the report of an adverse event not only impacts the individual facility, but the reputation of our entire community. So this collaborative is intended to support learning and implementation efforts to improve safety culture in nursing facilities. Next slide. Our contract with CMS is for 5 years, and as I mentioned, we're at the halfway point. The Nursing Home Collaborative is broken into 2 phases, so this is the beginning of the second phase. So you're in very good company. You might not realize that you're part of a national initiative to improve the quality of care in nursing homes. You are one of more than 10,000 nursing homes participating across the nation. 75% of nursing homes nationwide are participating. Next slide. So CMS challenged us to recruit 75% of the nursing homes in each state. The denominators on this slide indicate what our targets are, and each state over-recruited, so we have more than 75% of nursing homes participating for all of our states. Kudos to being overachievers. Next slide. Okay. We want to hear from you once again. Can you indicate whether you are part of the first collaborative? You can answer yes, no, or not sure. Okay, so what did we come up with?
One moment.
All right. So we seem to be split halfway between yes and no, and a percentage of us didn't answer. So I will say to those of you who said yes, welcome back. We'd love to invite you to comment on your experience in our chat room, and we're really glad you found value in not only participating in round one, but continuing your journey with us. For those of you newly joining the collaborative, welcome. We're excited to have you on board. And if you're not sure, reach out to your state lead who can share how your team may have participated in the past. Next slide. So the vision for this collaborative is to really help you build a strong culture of safety. We're going to do this by helping build capacity, strengthening safety, transparency, and also providing a quality-focused culture. Changing culture takes time, though. So be patient as we build trust and establish relationships within our long-term care community. The next 18 months is just one step in building the capacity of the long-term care community to tackle challenges and improve the care for people we serve. So remember when I said you were in good company? Here are just a few of our multi-state partners. We have the HealthInsight staff, nursing home teams across 4 states, beneficiaries and family members, the survey agencies, your state and local ombudsman, trade associations, the patient safety commissions for your state, and hospital systems. Our work takes a village, and we can't do this work without our partner organizations. Know that you're supported by not only your HealthInsight staff, but peers across 4 states. And again, beneficiaries and family members on our leadership team. We're working collaboratively with state agencies and associations. We're all involved to support your efforts. And please let us know if there are other organizations that you'd like us to reach out to support this collaborative on our journey. Next slide. So our approach and the tools that we're going to cover include a collaborative handbook to guide nursing homes. We're going to have a learning session developed and presented across the state. This is the first time that HealthInsight will be aligning our approach across all 4 states. Again, we've developed a handbook to give you some background and to serve as a resource for you through the next 18 months, and you'll be able to download this as part of the webinar. We're going to continue to put relevant, evidence-based resources on our website to guide your quality assurance performance improvement program and your performance improvement projects. Additionally, we will have available to you the Nursing Home Collaborative Change Package through the National Nursing Home Quality Care Collaborative. This is a book that focuses on high-performing nursing facilities and their common successful change strategies. Most of all, we've heard from you that you all value opportunities to learn from each other, so we will continue to all teach, all learn approach, and have opportunities for you to learn from peers in other states as well. So, before we move on, I'm going to ask Francesca to comment. Were there any particular questions in our chat room that we need to address at this time?
There were no questions related to the first section, but we did have some questions about CEUs.
Okay.
Kelly asks if CEUs will be Kansas approved.
Okay.
I'm sure anyone on our team will be able to answer that at this moment.
Kelly, I'm not sure. I think each state has worked on their CEUs a little bit differently, so perhaps that's something we can follow up with you on after the session. So now I'm going to pass the baton to Donna Thorson, the Nevada Program Manager, to talk about the goals and measures. Donna?
Thank you, Shannon. Next slide, please. We decided to focus this collaborative on resident safety, or in other words, the culture of safety. The Institute for Healthcare Improvement has an open school that anyone can use to learn about healthcare improvement topics. So I'm going to let Frank Federico explain what a culture of safety is.
Safety. And what does it mean to you? There are two definitions that I find which best reflect what it is that we are trying to achieve. And cultural safety is the product of the individual and group values, attitudes, competencies, and patterns of behavior that determine the commitment to and the style and proficiency of an organization's health and safety programs. Boy, that sounds like a real lot. How about if we just simplify it to say a culture of safety is how an organization behaves when no one is watching. Although there have been many efforts to improve safety, it seems to come back down to changing the culture of where we work. Culture is just not a touchy-feely aspect that is left to others to deal with. It is, in fact, the driving force that enables change to happen and to be sustained. There is a phrase that culture eats strategy for lunch. What that means is that you can have all kinds of plans, you can have all kinds of efforts to improve the quality of the organization, but in the long run, unless there is a culture in the organization that helps to achieve those goals, it all looks great on paper, but none of it will be realized. We have learned from aviation that a culture of safety must go through an evolution. We start with a pathological culture where we are not interested in improving. As long as nothing bad happens, we are not caught, then let's continue as we are. However, as the culture evolves, it becomes reactionary. That is, safety is important, and whenever we have an issue, we respond. Lots of activity after the fact. The next step is when we become calculative. That is, we spend time putting systems in place to prevent harm to patients from happening. We then become proactive. We work to anticipate harm before it happens and prevent problems. In the final step in the evolution, we become generative. That is, our focus on safety is how we do business around here. It is not a project. The culture of safety is how we do our work around here. How will we know if we have a culture of safety? First, safety is a core value. From the highest level of leadership in an organization down to the people who work every day, safety is key to how we work. Individuals are empowered to do the work that they must do to keep patients safe. An example might be that we do not support taking shortcuts for the sake of productivity or any other distractions that may prevent us from providing good care. Organizations that have a culture of safety include a component known as psychological safety. That is, individuals feel safe in speaking up, and they will not be punished or humiliated for speaking up about questions, concerns, or mistakes. Teamwork thrives in these organizations. Organizations with a culture of safety are transparent. That is, there is open communication and sharing with each other, with patients and families, with the community, and with other organizations. Organizations with a culture of safety use transparency as a vehicle for learning. One challenge that we have is that it has taken us quite some time to achieve the culture that we have in our organizations today. It will take some time to change it.
As you can see, there's quite a bit involved with the culture of safety, and that's why we've dedicated this collaborative that lasts 18 months to it. Next slide, please. This is the Institute for Healthcare Improvement Patient Safety Framework. It's from a white paper that was just released in March of 2017 titled A Framework for Safe, Reliable, and Effective Care. Our collaborative will address both culture and the learning system. The core of the framework is engagement of the patients and families. This is a reminder that the efforts to create this framework are about realizing the best outcomes for them. So let's briefly explore this framework moving clockwise. As Fred mentioned, transparency is being open and sharing openly with not just your staff, but your patients, your families, and other organizations. And we will be asking you to do that as part of the collaborative. Psychological safety isn't just about creating that environment where people are comfortable raising concerns and asking questions, but also that they feel comfortable suggesting new ideas and that we give them the opportunity to do so. That's a big part of the quality assurance performance improvement methodology. Teamwork and communication is about teams promoting We're promoting teams that develop a shared understanding and anticipate needs and problems, that apply standard tools for managing communication and conflict. Strong teams work together to plan forward, reflect back, communicate clearly, and manage risk. Negotiation, which also includes conflict management, is about gaining a genuine agreement on matters of importance to team members, patients, and families. The goal is to find workable solutions that manage resources, provide the best options for patients, and preserve the relationships between those people. Accountability means that we're holding individuals responsible for acting in a safe and respectful manner, and that they've been given the training and support to do so, and that we're not holding them accountable for the flaws in the systems and processes, but actually looking to improve those. Continuous learning is a huge part of being able to be the learning system, and that involves being proactive to identify and prevent potential harm, as well as learning from what works well. Reliability is the ability of the system to successfully produce the specific outcomes or products repeatedly. The object is to be able to apply best evidence and standard practices with the goal of failure-free operation over time. Improvement in measurement involves enhancing the work processes and patient outcomes using improvement tools, including measurement over time. Oftentimes we implement things to improve, but we do not measure what we're doing to make sure that it actually is an improvement. This is important to leverage improvement so that we can develop, test, implement, and spread those changes that result in better outcomes. And the final component of this is leadership. It's a critical component of both culture and the learning system. Leaders are called on to create an environment that promotes and facilitates teamwork, respect, and psychological safety. They are also asked to be able to apply the concepts of improvement, reliability, and continuous learning. To deliver the right care for every patient, every time, requires a new way of thinking about error in medicine and a new approach to preventing errors and harm. In the first learning session, we'll talk about how to move away from blame and punishment as a critical part of that approach. Next slide, please. The collaborative goals that we've identified are adapted from objectives from the Agency for Healthcare Research and Quality for resident safety. We are aiming to improve the culture of safety through leadership actions and proactive approaches to improve resident safety and interactions with employees. It's very important that we have the supervisors on the same page as the administrator and the director of nursing so that that approach follows down through the chain of leadership to the frontline staff. Next slide, please. The capacity for organizational learning is a big part of safety culture, and a strong QAPI program supports learning through the performance improvement projects involving frontline staff. As mentioned already, teamwork and communication are key pieces for a safety culture. So the collaborative will focus on effective communication methods and ways to engage your staff in training and skills development. By enhancing your capacity for resident safety, we believe you'll be able to improve your overall performance in nursing home quality measures, improve your performance in reducing the use of antipsychotic medications, successfully integrate the quality assurance performance improvement facility-wide, and enhance resident and family engagement. By the end of the collaborative, we want you to have a plan to sustain your project. However, approaches for sustainability will be included throughout the collaborative. Next slide, please. We are planning for 6 quarterly learning sessions with action periods between that include opportunities to meet virtually. Our plan is to provide content from each learning session on our website for future viewing, allowing the rural nursing homes to participate if they are unable to travel to the in-person events. More information will be provided on this after learning session 1. Our final outcome celebration will be in October of 2018. Next slide, please. You will be measuring your own progress, much the same way you already do, through the quality measures, your star ratings, and self-identified performance improvement project measures. In addition, you will have the opportunity to complete a survey on patient safety culture that will allow you to establish a baseline and measure progress with enhancing your safety culture. We will explain this more in a few minutes. So HealthInsight will be able to aggregate your results from the patient safety culture survey and measure change over the course of the collaborative based on completion of this survey during the first quarter and at the last quarter of the collaborative. The Centers for Medicare and Medicaid Services will be measuring us, HealthInsight, on your progress using the composite score of 13 long-stay quality measures. Next slide. The composite score is simply another way to measure overall quality of the nursing home by looking at a larger systems perspective. And these are the 13 long-stay measures that are part of the composite score. As a reminder, the composite quality measure score is calculated by adding the numerators from each of these measures to get one overall numerator, and then adding the denominators from each measure to get one overall denominator. Then the numerator is divided by the denominator, and the result is multiplied by 100 to get the composite score. Next slide, please. So we're going to now ask you to let us know which one of the quality measures is your top priority for the nursing home at this moment in time. And you'll see in the poll that each one of the 13 will be shown. Hopefully it will pop up here quickly. And you will indicate it by marking in the little circle to the left of the answer. Yeah.
Apologize, this is Lynn. We've got a glitch in our polling. Jennifer, the poll for slide 27 is missing. Is it possible to recover that? I apologize. I started that one. That's the one I started in error.
Slide 27.
Got it.
To be reset.
There we go. All right, so you'll see each one of the 13 measures there, and all you want to do is select the one that you're most focused on by clicking on the circle to the left, and then clicking the Submit button down in the bottom right-hand side. This is important to us because we want to know what it is that you're looking at and allowing us to help support you in moving forward on that quality measure.
One moment, please.
Well, it looks like the majority has no answer, but we do have quite a few that are focused on falls with major injury, and that is definitely a resident safety issue. Look forward to hearing more about that as we move through our collaborative. Next slide, please. We wanted to show you where each state is currently with their average composite scores. The dark dashed line you see at the very bottom is the target goal of 6.0. Just above this is the national score with the dark red line, and that is 7.8. Beginning at the top, you'll see the dark blue line is New Mexico with an average of 10.2, followed by Nevada in light gray at 9.5, Oregon in orange at 8.5, and Utah in light blue at 8.1. The target composite score of 6 or less was identified by the Centers for Medicare and Medicaid Services before the collaborative even began in 2014 with our first collaborative. What they did was they looked at the composite scores for every nursing home nationally and identified that approximately 10% of the nursing homes had already achieved a score of 6.0 or less. And that was established as the standard to designate quality overall quality for the nursing homes. And as you can see in this graph, all of our states have made progress towards that national target. Next slide, please. This graphic shows you our progress as all 4 states towards the goal of supporting you in reaching the target of 6.0 or less. As of September 30th, 2016, 33.6% of participants, that is 89 nursing homes out of 265, have met the target composite score of 6.0 or less. HealthInsight's goal is to have a minimum of 50% of nursing homes reach the target by October of 2018. And we are confident that you will be able to achieve that. Next slide, please. Now we'd like to get an idea of how many of you have been paying attention to your composite scores when those reports come to you quarterly. If you would just take a moment to let us know if you are aware whether or not your nursing home's composite quality measure score has dropped below 6.0 since April of 2015 or not. And it doesn't look like the poll has actually been opened yet.
It hasn't?
Okay.
Oh, there we go. All right, so it looks like about half the people said yes and half said no. We had another large segment that didn't answer, and I don't know if that's because of the poll or not. But we want to let you know that if you have not yet met it, or if you're not aware if you've met it or not, please contact your state lead to get some support in moving forward to address the composite score or to find out what your composite score is currently. Next slide, please. This chart shows that the same 5 quality measures out of the 13 are contributing most to the average composite score in all 4 states. That dark blue bar that you see on the left-hand side of each one of the graphs is incontinence, and it is the biggest contributor for all 4 states. In fact, national data shows that incontinence is a challenge for everyone. The dark gray bar is activities of daily living. The light orange bar is antipsychotic medications. The dark orange bar is pneumonia vaccination, and the light blue bar is pain. As you can see, these 4 quality measures change positions depending on the state, but they are all the same 5 quality measures for each state. I'd like to remind you that HealthInsight has resources to assist you in tackling all these measures on our website. We also intend to weave additional resources into our learning sections as we move forward. Next slide, please. To accomplish our collaborative goals, we're going to employ evidence-informed practices from a national level, as well as the expertise throughout our own regions in an all-teach, all-learn environment. We will address both quality measures as well as the culture by addressing domains from the Agency for Healthcare Research and Quality Resident Safety Surveys. Before we move on, Francesca, are there any questions in chat?
There are no questions regarding on this topic.
All right, thank you very much. I'm now going to pass the baton to Michelle Carlson, the Utah Project Manager, to discuss the AHRQ resources we will be using. Michelle?
Thank you, Donna. The Agency for Healthcare Research and Quality, or AHRQ, is the lead federal agency charged with improving the safety and quality of America's healthcare system. AHRQ develops the knowledge, tools, and data needed to improve the healthcare system and help Americans, healthcare professionals, and policymakers make informed health decisions. In 1999, an Institute of Medicine report, To Err is Human, documented serious patient safety problems in our healthcare system. In the intervening years, AHRQ has led the nation in responding to those issues and improving the safety of healthcare. Using AHRQ's research and how-to tools, the U.S. healthcare system prevented 1.3 million errors, saved 50,000 lives, and avoided $12 billion in wasteful spending from 2010 to 2013. But even with these successes, safety is far from optimal, and AHRQ's work continues. Next slide, please. The AHRQ Resident Safety Culture Survey was developed to help leadership identify areas that can improve resident safety within long-term care facilities. The intention is that all staff within a nursing home will take the survey, which takes less than 15 minutes to complete, and submit their responses anonymously. HealthInsight is offering to assist each nursing home in the collaborative to fill the survey and will generate summary reports based on the results for each nursing home. This is quite an intensive process on our end, and we encourage you to take advantage of this free service, which we will offer at the beginning and again at the end of the collaborative. We're going to do another poll here and ask you to let us know if you have used the AHRQ survey in the past. Do we have that poll?
Chat question.
Oh, I'm sorry. Could you please let us know in the chat box if any of you have used the AHRQ survey in the past? And we'll give you just a couple of seconds to answer that. So please put that in the chat. Francesca, is anyone chatting their answers?
We have a lot of people saying no, some people saying they're unsure, and some people saying that they have.
Okay, great. So a little bit of everything. We can go to the next slide, please. So if you choose to complete the survey for your nursing home, this is an example of what will be included in the report. Just give you a couple of minutes to look at that. Next slide, please. On this slide are the 12 domains of the survey with national average positive response rates by nursing home staff. So you can see it asks about overall perception of resident safety, feedback and communication about incidents, supervisor expectations and action promoting resident safety, organizational learning, training and skills, management support for resident safety, teamwork, compliance with procedures, handoff, communication openness, non-punitive response to mistakes, and staffing. Overall, nursing homes are doing well at the overall perception of resident safety, feedback and communication about incidents, and supervisor expectations and actions promoting resident safety. Areas for improvement include communication openness, non-punitive responses to mistakes, and staffing. Your individualized summary report will show you how your nursing home compares to the national rates for each domain. Each nursing home will receive an email within the next week with a short questionnaire asking if you would like to take advantage of this opportunity to fill the survey with your staff, and if so, whether you prefer to conduct the survey by paper or via a web link to complete the survey online. Either way, if you choose to fill the survey, we encourage it to be filled to all staff. Also, if you choose to fill the paper survey, we have found that we get a much larger return rate if the survey is offered during one of your off-staff meetings, and we will provide all promotional and survey materials. We believe the results of this survey can be an excellent tool to help guide your performance improvement projects throughout the collaborative. Since this is not a required activity, we will only send out the email, one email request. We will not pester you on this one. However, there is a deadline that all surveys must be completed not later than June 15th. So if you're interested, please let us know via the questionnaire. Next slide, please. Now we have a poll on how would you prefer your staff to complete the survey? By paper, online, or not sure how best? Give you just a couple of minutes to answer that survey. For the poll, excuse me. You can see the questions there, paper, online, or not sure how best. The poll has ended, so we should be getting some results here shortly. It looks like the majority of you, about a third of you, would like to have your staff do the survey by paper. Another 17 of you online, and there are a couple of people that are not sure how best, and a lot of you that did not answer. So hopefully you can watch for the email and let us know so that we can start helping those of you that want to complete the survey. Next slide, please. So next we're going to show you what we have in mind for the collaborative content. We're going to be using the AHRQ safety program for long-term care, covering healthcare-associated infections or acquired infections, catheter-associated UTIs, and the long-term care safety toolkit. So session 1 will cover applying safety principles. Session 2 will cover senior leader engagement. Session 3 is on staff empowerment. Session 4 is on teamwork and communication. Session 5 will be on resident and family engagement. And Session 6 will be on sustainability. Each one of these sessions will address various domains of the safety culture. Content is based on the 6 modules that we just discussed. And then woven into the content throughout the modules will be guidance on strengthening your QAPI program, developing and implementing your antibiotic stewardship program, and we will also address issues that impact on sustainability during each learning session in order to promote a strong culture of safety. Francesca, do we have any questions before I turn the time over to Leah Brandis?
Betsy had a question about composite scores, and she's wondering if they're the same thing that they pull at their facilities for their quality measures.
This is Leah Brandis, and no, they're not, and I'll talk a little bit more about that in my section towards the end. But the composite score is a combination of the 13 quality measures.
Great. And Krista wanted to know if the survey was completed just by management or by all staff.
No, it's a survey for all staff. We would encourage as many staff as possible to fill out the survey.
Great, thank you.
Any more questions?
That's all in the chat.
Okay, at this time I will pass the baton to Leah Brandis, the Oregon Project Coordinator.
Thank you, Michelle. We are using standard QAPI concepts as the backbone of our performance improvement projects. We assume you already have a QAPI team in place and are engaging all staff in the QAPI program and in implementing performance improvement projects. The collaborative is designed to support the QAPI program you already have in place and not to be an additional project. We will encourage the use of common quality improvement tools such as the Model for Improvement and PDSA cycles. We hope that you will take advantage of the AHRQ Resident Safety Survey to identify areas for improvement so you can address the culture in your community, which will lead us to a culture that prevents harm. And in addition to crafting aims to address quality measures that are meaningful to your community. We also encourage you to take advantage of the resources at HealthInsight and don't hesitate to contact your state lead and check out the resources on our website before diving into a performance improvement project to ensure you're not attempting to recreate the wheel when you don't have to. Next slide. We encourage the use of the model for improvement, which guides us in asking 3 questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? We will ask that you pick an aim related to either your AHRQ resident safety survey results and or your quality measures, and be prepared to report back to the group. We encourage you to monitor and modify your efforts for effectiveness. Make tweaks to your plans and repeat multiple plan, do, study, act cycles that will result in improvement over time. We don't expect your first time to be perfect, so build in the expectation for multiple small tests of change. All participation in the collaborative is voluntary, and the more you invest in the collaborative, the more your team will benefit. We ask that you complete the pre-work and action period activities, send team members to the 6 learning sessions, implement changes in your building and evaluate the results, gather data, and openly share with other collaborative participants and HealthInsight staff. HealthInsight's role is to coordinate and facilitate 6 learning sessions and coordinate opportunities for peer exchange in an all-teach-all-learn environment. We will help you compile the results of the AHRQ surveys into a meaningful report to identify areas of strength and areas for improvement in your building's culture. We will also complete and distribute quarterly composite quality measures for reports to help you track your progress and compare your performance to others. We will also provide technical support, including webinars and conference calls. Since collaboratives are taking place in every state, we have partnered with 18 states to provide monthly webinars on topics that may be of interest to you. These are optional, but if you see a topic that aligns with a focus area for your building, please take advantage of these 1-hour webinars. We also try to record these webinars, but the links may be hosted on another state's website, so please let us know what you are interested in so we can point you in the right direction. The next upcoming webinars are Mealtime, Making the Greatest Impact in 60 Minutes, and a Team Steps Long-Term Care Communication module in May that will address staff communication tips. In June, Sue Ann Gilderman will be presenting a webinar on sleep hygiene and the relationship to fault. If you hadn't heard Sue Ann speak, I highly recommend that you attend the program. We developed a collaborative handbook that is available for you to download now in the download section of the webinar or on our website. This handbook is intended to be a resource for you now and through the duration of the collaborative. It summarizes the planned activities, a timeline, the measures, learning session content, how to contact us, and we provide a resource section with hyperlinks to learn more about QAPI, the AHRQ, the IHI, and the change package. So the first face-to-face learning session is next month. Your pre-work includes completing a QAPI self-assessment tool off the CMS website, and there's a link on this slide, and then completing a 2-question survey summarizing where you are in your QAPI program by May 1st. We'll be sending emails with these links as well. We also ask that you be thinking about the culture of resident safety in your building over the next month and come prepared to discuss such topics as root cause analysis, event documentation, employee corrective action reports, safety committee minutes and policies, code of conduct, an employee handbook, and your employee orientation. We also ask that you assess your current quality measures and identify what quality measures your team needs to focus on in the coming months. You can use your pass-through reports, internal reports, and the HealthInsight reports that will be sent out either in the coming months or last month in March. We will be distributing quarterly composite quality measure score reports. Here is an example. The red dashed line represents the national target, The orange line is your state average, and the blue line is your nursing home. You can share this report with your QAPI team to show progress over time. As you can see, this nursing home is hovering very close to the national target recently. The bubble chart below helps you identify which quality measures are contributing most to your composite score, and it may be useful when looking at where the low-hanging fruit may be to get your composite score down. This page shows you the 13 individual quality measure run chart, which can help you identify trends. These are trends that you can celebrate with your team, as well as help you identify areas for performance improvement projects. For example, in the pain run chart on the left lower side, there you go, you can see a nice trend downward over time with a small uptake in this past quarter. This indicates that overall your team is on the right track, but you might consider talking to your team about what might have caused the recent uptick to see if some attention is needed in this area. And knowing that you're all a very competitive bunch, we know that this is your favorite chart. Each blue bar represents one nursing home's composite score. The orange line represents your facility, so you can see where your team stands in comparison to the rest of the state. We know that you are all vying to move your orange line to the very top. So some of you skeptics are still wondering how this will all benefit you. Everything you do to improve resident safety culture will enhance the quality of care you provide. And I often hear that it can be hard for leaders to keep the fire burning and motivate staff to constantly be improving, and we hope to make it just a little bit easier. We encourage you to identify informal leaders in your building and send them as well to our learning sessions to keep them energized. And what we hear over and over is that you appreciate networking with your peers and that relationships that are built through collaborative efforts result in sustainable community collaboration. Even those of you who are confident in your QAPI program always can use a little polishing and motivation for your team to maintain the high standards that you set. Of course, you'll see improvements in your quality measures and 5-star rating as you complete performance improvement projects, and we expect your hospital readmission rates to go down. A subgroup of the collaborative will be focused on the C. difficile infection rates as well, and everyone will have access to the resources that we provide this group, which will help you support your infection prevention program and policy your antibiotic stewardship program. We want to assure you that what we are asking you to do has been piloted with great success. Highland Manor of Mesquite participated in a special project to improve the culture of safety and reduce the number of catheter-associated urinary tract infections for their residents. The project began in April 2015 and ended in May of 2016. As part of the project, the nursing home was asked to have their staff, including all departments and all shifts, complete the AHRQ Safety Culture Survey. When the summary reports were provided, leadership at Highland Manor were surprised that they had less than 75% positive responses for 3 areas: communication openness, handoffs, and staffing. The team explored options for improvement with the staff and piloted safety huddles. This gave the staff the opportunity to talk to each other about safety concerns with specific residents, such as fall risk and hydration. Then they provided an overlap in shift changes for CNAs so that they could share this information between shifts. Finally, leadership realized that they needed to listen to the employees' safety concerns to better understand situations. This resulted in having the necessary equipment and tools available to the staff, including the access to the right incontinence care products. While focusing on improving the safety culture, nursing staff also received education and training on skills to prevent UTIs along with tools and resources. In addition, workflows and protocols were established to ensure practices aligned with the best evidence available. They also included a daily practice of assessing each resident with a catheter to determine if it was still needed, and removing the catheter as soon as it was no longer medically necessary. Atlee Manor has sustained practices that prevent UTIs and the unnecessary use of catheters. This performance improvement project incorporated changes to both the culture and the clinical knowledge and processes, improving the quality of life for the people that Atlee Manor serves. And that story reminds us that the real goal of all of our efforts is to maximize the quality of life for the people that we serve. We at HealthInsight are very excited for this collaborative. Working together with all four states has really enhanced our planning process, and we are having fun putting together these sessions for you. We are looking to include the most current evidence and experience of experts in the field, and hope you find the information informative and the sessions with your peers energizing. We look forward to working with all of you because your input and engagement will enrich the experience over the next 18 months and ultimately guide this collaborative toward making a lasting positive impact on your staff and residents in all four states. Next slide. Adanya, can you remind folks how to get in the queue for questions?
Ladies and gentlemen, if you would like to ask a question, please press the number 1 queue. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 queue.
We had a question in chat regarding the surveys, and Janelle would like to know if contracted employees, like people in the therapy department or housekeeping and laundry, also fill out the survey.
Yes, that would be appropriate.
We'd like for everyone to be included in those surveys.
Ladies and gentlemen, again, if you would like to ask a question, please press the number 1 key. Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Currently, there's no one in queue at the moment.
This is Lynn again. There was also a question about who do we email for the survey. We're going to be sending out an email to all of you and those that are not on the call today sometime next week that will give you a link to a Survey Monkey to let us know yes or no you would like to do the survey, and if you want to do paper or online, just a couple of quick questions, and then we'll follow up with you. I think the key thing is if you are thinking that you want to field it, if you're wanting to field it on a paper survey, with our June 15th deadline, if you've got an all-staff meeting coming up either here in April or May, those we've found a lot of success with fielding those during the all-staff surveys or all-staff meetings. It takes about 10-15 minutes to get everybody gathered. We get a really nice return rate that way. And then we also have a process for leaving surveys for staff who are not in attendance, who might be working or just off that day, and a process to keep everything confidential. So we'll go over all that once you all sign up.
Okay, we do not have anyone in queue right now.
All right. So for next steps for today are to complete and submit your QAPI SurveyMonkey status by May 1st, to read through the handbook, register for Learning Session 1, and sign up for the AHRQ survey. You will be receiving some emails in the coming weeks, and so be looking for those emails and making sure to take action on the ones that are indicated. So for those of you who are spread out throughout the different regions and different states, you will be getting emails that identify the locations that are available for the learning session in May, and you will be able to select a location that is most convenient for you. So there will be sessions available throughout all 4 states, and throughout different regions within each state so that hopefully you can find one that works best for you and your team. So be looking for those emails and take action when you receive those emails. Next slide. Oh, there's another question.
So there's a question from Stephanie that with your organization, you've got a skilled nursing facility, 1 memory building, and 3 outbuildings. And would the survey be just for the nursing home? That's a good question. I think if you could contact your state lead, I'm not sure which state that you are from, and we will have a response for you.
All right. Are there any additional questions? Feel free to put them into the chat box at this time. Otherwise, as you close the webinar today, you will be prompted to complete an evaluation. If you want CEUs, please complete the indicated fields so that we can send you the CEUs. Next slide. Here is our contact information, and these slides are available to download from WebEx, as well as we'll include them in an upcoming email for you. So please call or email us anytime with questions. Finally, we'd like to thank you for committing time to this collaborative. We know that many of you are involved with other groups and that you are committed to improving quality care. Thank you for your time today.
Ladies and gentlemen, thank you for joining. You may now disconnect.